Hello, my name's Steve McClave. I'm going to be the moderator of this symposium, and it's entitled Nutritional Experience in the ICU and Post-Discharge, Impact on Patient Care. The objectives for this symposium, we're going to look at protein recommendations across the continuum from ICU to rehabilitation, and we're going to look at tube feeding intolerance and the use of small peptide MCT formulas in a group of patients on home enteral nutrition in Rochester, Minnesota. I'm your moderator, Steve McClave. I'm a gastroenterologist in Louisville, Kentucky. Zudin Puccicherry is one of my favorite speakers. He's an intensivist pulmonary critical care doc from London. He's at the Queen Mary University in London. And then finally, again, one of my favorite speakers, Manpreet Mundi, a rising star with ASPEN, an endocrinologist and former Nestle Fellow at Mayo Clinic in Rochester. He's the director of the Home Enteral Nutrition program, and he's the one that will talk about use of small peptide MCT formulas for home patients with feeding intolerance. We'll move on now and listen to Zudin Puccicherry talk about protein needs across the continuum of care.
Hello, everyone. I'm going to talk about protein needs across the continuum of care. As Steve pointed out earlier on, that perhaps I might have a slightly different view from many of other speakers, and I think it's important to point out that I do this. It's all about improving the field of science to improve the care of our patients. My disclosures: I work with these various companies, either giving talks, but more specifically developing new compounds for the prevention of muscle wasting in critically ill patients. So when we talk about protein in the continuum of care, I think it's important to discuss what we mean by the continuum of care. So I think first I'm going to start to define acute and chronic critical illness. If you look at trials which have defined most of our acute critical illness periods, we've looked at most trials look in the first weeks, 0 to 7 days, to define acute critical illness. And separately, in some of our epidemiological work, we've seen over and over again that there's a transition to this thing called persistent or chronic critical illness sometime between 7 and 10 days. And it's startling that every single academic group who looks for this looks to find between 7 to 10 days. So there's a spectrum of time around this, which affects 16% of our patients. But these 16% of our patients consume between 25 and 50% of our healthcare resources. So we have this transition between acute and chronic critical illness. The problem with these definitions that we have now is that it's very difficult for them to make a difference at the bedside because they don't really take into account inter-individual variation and allowing us to make those judgments at the bedside. So I much prefer the biological response to insult approach, whereby we look at acute illness being a period of multi-organ failure and a systemic inflammatory response syndrome, and then a development of chronic critical illness as one develops markers of persistent inflammation, immunosuppression, and muscle wasting. And this was first described by Judith Nelson recently, well, not first described, it was described a little while ago, but this particular conceptual framework comes out of the Gainesville group, and they described this in 2010. And I'm going to come back to this. So we'll start with acute critical illness when we have multi-organ failure and the systemic inflammatory response syndrome. And I'm just going to put it out there that protein delivery in acute critical illness has yet to convincingly show functional benefit. I'm going to start by saying, I'm going to go back to Steve McClave's talk and say, looking at the quality of evidence is really, really important. Looking at where you derive these statements from is very, very important. So I'm going to quote Steve, who says, I mean, obviously it's a huge group of people writing this, but in the ASPEN guidelines, it suggests the high dose protein should be provided. Requirements are 1.2 to 2 grams actual body weight. Quality of evidence, very low. That says to me, that's not very convincing. On this side of the pond, we've got, during critical illness, 1.3 grams per kilo protein equivalent per day can be delivered progressively. Greater recommendation, 0. No evidence to support this, but a strong consensus. So, as a clinician treating patients, I think you have to say that we're going on best opinion, but without evidence-based practice. So what we have currently in the we have Darren Halen's group, which is a huge, almost consortium approach to randomized controlled trials, looking to build the EFFECT trial. Well, they're doing a multi-center registry-based trial looking at high-dose protein versus low-dose. This year, the ANZIX group just finished their target protein feasibility trial, where they plan to go for high-dose protein versus conventional treatment in the same fashion as their target calories trial. So we'll see whether these things can be tested in prospective randomized controlled trials at large numbers. In the meantime, it's important to consider the science behind these recommendations. So just to remind you that in a critically ill person, muscle protein synthesis is decreased on the first day of critical illness to levels associated with our fasted controls despite the provision of feeding. And there's variable recovery over the first 7 days. And protein synthesis is incredibly important because we need to increase protein synthesis to increase muscle mass and improve functional outcomes, which is the basis of what we're trying to do right now with nutrition and our patients. What we often don't talk about is the energy component of protein production. And 40 to 60% of all energy, or ATP, in our cells is used for protein synthesis. So it makes no sense to a physiologist or biologist to separate proteins and calories. To give more of one without the other seems nonsensical. And I think the same would be true for our patients. Patients don't recognize guidelines, they just do what they need to do. So if you look at the energy requirement for protein synthesis being this high, we ought to look at how much energy we generate. Well, in earlier talks, we've talked about some of our data where we looked at ATP content. And the ATP content of muscle in the acute phase is low. What we have here on the first day of critical illness, patients dropping ATP content significantly. Obviously, there's heterogeneity in this, and patients with chronic disease drop their ATP content far faster than those without chronic disease. And this is true of the exercise literature. If you took myself and someone with COPD, we would both have the same resting ATP content, but if we did exercise or had any form of metabolic stress, someone with COPD would drop their ATP content faster. Regardless, over the first week during acute critical illness, patients drop their ATP content despite the provision of nutrition. And in other talks at ASPEN, we've talked about why this is because of the inability to metabolize carbohydrates from hypoxic inflammation and impaired beta oxidation. I don't want to go back over that, but we have to think about what the implication of impaired protein synthesis will be in the acute phase of critical illness when you then give people protein. So I'm going to share with you some unpublished data, which we're going through at the moment. I'd be grateful if you wouldn't tweet this. And then we teamed up with Darren Halen's team group and to look at the Redox trial, which many of you will be familiar with. So this is a randomized controlled trial of 1,223 adult critically ill patients who were randomized to supplemental glutamine, antioxidant both, versus usual care and 28-day mortality outcome. And the original trial showed a increase in mortality with glutamine with an odds ratio of 1.28 and an increased hospital mortality and 6-month mortality. And one of our PhD students, Ryan, who was meant to be at ASPEN, but clearly is not, is performing or has performed a post hoc secondary analysis to describe the 90-day risk of death associated with different urea to creatinine ratios trajectories among patients with multi-organ failure. Why this? Well, if we look at the urea to creatinine signature, we think that this probably embodies a sort of a biochemical signature of muscle wasting and cachexia in the critically ill patient. Bearing in mind the first descriptions of urea to creatinine ratios that came a long time ago, pre-PubMed, pre-Google, possibly pre-Steve McClave. I don't know if that's possible, but this is true. Okay, so talking through this, we have critically ill patients. Sorry, Steve, I couldn't resist that.
You're in trouble.
So critically ill patient has this is I know this is a busy slide. This is the only major biological thing I'm showing you, okay? So, yeah, multi-organ dysfunction, inflammation, abscess, and mobilization, plus exogenous nutrition gives us lots of protein broken down, taking up energy and releasing ammonia. More glutamine results in more ammonia production, and all this feeds into the urea cycle and generates urea. Urea being probably a surrogate of all this ammonia being produced, increasing your urea. At the same time, we're increasingly understanding that creatinine is not a good marker of renal function. And in fact, some work from John Prowl at Royal London, the Karolinska Institute, and from Gainesville, Florida, are all showing that creatinine is really a marker of muscle mass, and it decreases rapidly over time in a critically ill patient. So what we think we see is this urea to creatinine ratio, where the urea goes up when you're sick and creatinine goes down, is a marker of abnormal metabolism. That's the hypothesis, okay? So we took the data from the redox trial, because the redox trial was fabulously carried out, has so much rich data for us to learn from. And we used cluster analyses to see, are there different clusters of urea to creatinine ratios? And three groups turned out. We then looked at survival within these clusters, and this is what we saw. If you had a low urea creatinine ratio, you have this trajectory of survival, and as your urea to creatinine ratio increases, you have an increased mortality. And there are reasonable numbers of patients on day 10 with urea to creatinine ratios. So we're looking at about studies of 500-600 patients. So in this analysis, increase in urea creatinine ratio, our purported biochemical signature of protein dysmetabolism, I guess, is associated with mortality. So we went back, because what we're saying is that this urea is being generated by both endogenous protein and exogenous protein. And we modeled and said, well, what happens if we have all these different levels of exogenous protein when you're critically sick and in multi-organ failure? And this is what we saw. If you had normal metabolism, then you do actually have some separation with increased protein. But if you're one of these people who has a high urea creatinine trajectory, i.e. you've developed abnormal metabolism, then the provision of extra protein increases your mortality. Now, you may think, gosh, that's new, but actually it's not new, because you can look at the EPANIC trial, you can look at our observational work in the past to suggest that in some patients, high protein concentrations are dangerous. And I think this would be really interesting to see how this comes out in the EFFORT trial. So Darren's going to put the urea creatinine ratio into one of as a sub-study into this. But it comes down to this concept of personalized medicine. Do you really think that every patient has the same requirement? Do you really think that every patient undergoes critical illness and has the same changes in metabolism? I don't. I think some people respond differently to critical illness. And for those of us going through the COVID-19 pandemic, we're seeing that in front of our eyes right now. We can't tell why some patients do badly and some patients do well. And so our working hypothesis is that we can pick out these people. And I've noticed that I'm saying it's a working hypothesis. I'm not saying go out there, I've solved this. I'm saying in a prospective randomized controlled trial, we're going to test this to see whether in those patients with raised urea to creatinine ratios, exogenous protein increases the risk of persistent critical illness, as we did in Ryan's paper, original paper, intensive care medicine. Is it increases the risk of low return to home rates? This paper in Crit Care Med, published just a couple of months ago, found the same thing. And does it increase the risk of mortality, which is what our recent reanalysis of the redox trial shows. So this is why we stand on acute critical illness, in that there was clearly a group of patients who don't do well with increased protein in acute critical illness, and we need to understand who these patients are before we have blanket recommendations to give a lot of protein to everybody. If we move on to chronic critical illness, well, what do we mean by this? We have acute critically ill patients. Some survive, some die, and some do neither. And they're stuck on the intensive care unit, with huge amounts of muscle wasting and the need for ventilation in many cases. But we've updated this to say that these people who are on the intensive care unit requiring single organ support, including renal replacement therapy. And we know that these cachexia syndromes can last for a long time. Well, we described the first week, Lena Gammon-Grippenberg from the Karolinska Institution described what happens in long-stay ICU patients. And it can take up to 30 days for protein synthesis to normalize. And at this stage, protein breakdown increases, giving us our persistent cachexia state. Now, in this setting, we have a lot of problems. Patients have been immobilized for quite a while in chronic critical illness. And immobilization is a problem in that it's an anti-anabolic stimulus. It will prevent muscle growth. And we know that despite all these discussions that we have about early mobilization, we just don't do it well. These are recent, this is a slide from Linda Dennehy, who gave me, showing that actually across the world, even in centers that don't that have mobilization champions, we're very bad at mobilizing non-intubated patients and very bad, even worse at mobilizing intubated patients. And I'll put it to you that some of the work that actually we may think we're very good, but when you look at this subjectively, this is not true. So ask yourself, has there been objective evidence in your intensive care unit that you're very good at mobilization? We'd like to think that you can perform exercise on these patients, and exercise plus nutrition builds muscle. Unfortunately, the critically ill patient who's recovering in chronic critical illness has a very, very low tolerance of exercise. So this is some work done from the Netherlands that shows that the median duration of exercise in a chronic critically ill patient was 6.1 minutes at 5 watts with a Borg score of 13. So that means it took them 6 minutes to get into the chair, and they found that very, very, very breathless, very, very distressing, and made them very breathless. That is not sufficient exercise. So a chronically critically ill patient can't do exercise, which is what you need to do in conjunction with feed the patient. So nutrition in this setting needs to take into account the exercise. Inflammation is the second thing. So the chronic critically ill patient is inflamed. That is one of the hallmarks of it. So this is some very old work, again from the Karolinska Institute, showing that if you inflame people, they drop their muscle protein synthesis. And the critically ill patient has intramuscular inflammation. This is some work we looked at muscle biopsies, and we found a large number of intramuscular cytokines by day 7 in these critically ill patients. And this has been shown repeatedly by other groups. While you're inflamed, therefore, when you're chronically critically ill, it's pointless giving people more protein or doing exercise. One, because they can't do the exercise, and two, because they can't use the protein. So protein nutrition in this setting needs to be done in the context of inflammation too. And all this results in substrate switching. As you become more and more inactive, you're less and less able to use glucose efficiently. And this is what we see in the critically ill patient. We have insulin resistance in people who are immobilized, and Stefan Weber Carstens demonstrated the biology behind insulin resistance in the critically ill patient, that of poor GLUT4 translocation. We're less able to use fats in the critically ill when you're immobilized, and we showed a couple of years ago that beta oxidation is impaired, and we discussed this earlier on in the metabolamics session. As a result of this decrease in beta oxidation, an immobilized patient builds up intramuscular lipid, and so it is as a critically ill person. And so you're unable to generate ATP for use for protein synthetic, for protein, muscle protein synthesis. So in summary, in the chronic critically ill person, so I'm showing the ASPEN guidelines in the ASPEN talk conference, but that's what I've been asked to do. We have to think about physiology, okay? We have to think about the acute phase, and we have to think about when patients have an increase in anabolism and are able to start thinking about rehabilitation. And this is not going to be a day-related thing. It's going to be related to biology and individual patient factors. And we know this is happening because if you look at some work from Nottingham where they biopsied a whole bunch of patients, they can see changes in mRNA. So this is the bits, the genes that go on to develop the proteins for anabolic signaling. But at the beginning, these genes are not being translated into proteins, i.e. they're sitting there waiting for the moment to start building muscle. So there's an initiation of cellular program of anabolic restoration ready for the right time, when inflammation has gone away, when people are no longer immobilized, to start anabolic restoration. And that is the time to give protein. And if you don't, we just give protein in a fashion like this, what you see is this. This is Ryan's first publication last year, showing in a trauma population that the urea to creatinine ratio, what we think is our marker of abnormal protein metabolism, predicts persistent critical illness far better than any of the other epidemiological techniques used. And this is probably related to a combination of nutritional protein and catabolism, which is what I've just shown you. I'm going to finish off to point out two other things against blanket rules. Remember that nutrition and exercise as a combination is needed to stimulate muscle protein synthesis. So your protein recommendations need to take into account exercise and the performance of exercise. Secondly, we've known this for a long, long time, that the protein requirements need to be age-related to great muscle. In our lives outside intensive care, we're well used to the reverses, that young people eat huge amounts of protein, but you only need 0.25 grams per kilo to stimulate muscle protein synthesis, whilst older people eat less protein when they need far more protein to stimulate muscle protein synthesis. And none of our guidelines, the ASPEN, Australian guidelines, Canadian guidelines, take into account age of our patients and the personalized need for this. So where we are right now, I'd summarize this by saying there's no good evidence for blanket protein delivery during the acute phase. At this stage, it's more important to do things in a systematic fashion than it is to go off tangentially. And my unit follows the ASPEN guidelines. I still think protein delivery in the chronic phase needs to be considered alongside energy delivery and exercise, and you're seeing this coming through in the physiology of the ASPEN guidelines. And right now, we're developing new bedside markers for nutritional response. Thank you very much.
Let's finish up with Manpreet Mundi. If we'll go to the next slide, Manpreet's going to talk about management of home enteral nutrition and what happens in the patient that can't tolerate tube feeds. Manpreet?
All right, thank you. Hope you can hear me okay. But I'll take over and kind of talk about the post-discharge part of the conversation. And I think this is important to have because exactly what you described, Dr. McClave, in that more and more patients are now having better survival when through their critical illness. And so more and more patients are being discharged, and many of them need ongoing enteral nutrition. So these are my disclosures that are pertinent to this talk. And what I hope to do is share some data really about the home enteral nutrition population in general, which is rapidly growing. Talk about the difficulties that we continue to have both in the ICU as well as hospitalized patients and then post-discharge in terms of intolerance. And then some of the data that's emerging, especially from our own sort of review of our patients, that says maybe we aren't managing these patients as best as we should. So with that, I'll start with a case. I always like to ground myself in the patients that we treat. And this is a 50-year-old lady that we saw, had a history of obesity, complicated by diabetes as well as reflux. And she had a history of a Nissen fundoplication in 1999. But unfortunately, her symptoms of reflux returned in 2013. And at that point, the decision was made to convert her to a Roux-en-Y gastric bypass. So after she underwent this surgery, unfortunately, she started experiencing a great deal of postprandial abdominal pain. So initially, dietary changes were made, but there was no response. So they started to do further workup. And one of that workup was the upper GI series, which showed that there was a deformity in the gastric pouch. And so EGD was also done, and again confirmed that perhaps the gastric pouch was too large, greater than 20 centimeters. So with this, decision was made to revise her surgery again. Unfortunately, that didn't solve the problem. She continued to have pain, nausea, and now even vomiting. CT scan was done to see if we missed anything else, and there was a finding of peripancreatic fluid collection that was drained, but unfortunately no resolution of her symptoms. So then another EGD was done. They thought there was a possible stricture in the EJ anastomosis, and that underwent dilation. But again, symptoms just continued to persist. Her weight during this time also began to decrease. And so we were starting to worry about malnutrition in this patient as well. Now, we don't have any questions and answer, but I just want you to think through. At this point, you're seeing this patient in your clinic, what should our next step be? And as we kind of work through this and look at all the choices, one choice is, do we still try to make oral intake work? Do we have her visit with a dietitian and see if that can work? Another option is, do we switch her to enteral nutrition? And again, how would we do that? Do we do that through a nasal jejunal tube? Do we put in a gastrostomy into that remnant stomach? Or do we think about parenteral nutrition? Do we think enteral is just not going to work? But again, looking back at the data, when we start to look at this decision we have to make, we can see that there's significant data that shows benefit from enteral feeds. And I think Dr. McClave says this best: if the gut works, we should use it. And so, I won't go through the details of this, but there's a lot of benefit in terms of preservation of architecture, in terms of immune benefit, and also our friends, the microbiome as well. There's also been studies that have looked at this, comparing early enteral nutrition versus other sources of nutrition, maybe even late enteral nutrition, and again, showing benefit in terms of early enteral nutrition. Critically ill, we've just had 2 great talks on this topic. Lots of data supporting early enteral nutrition in these patients. Also, I think, as we're seeing more and more data, parenteral nutrition is getting better and better and coming closer to enteral nutrition, but I don't think it will ever take over in terms of the cost comparisons. So I, along with Zudin, am also showing ASPEN guidelines in an ASPEN talk, but unfortunately, we are still progressing towards the ASPEN guidelines on home enteral nutrition. So I'll be using the ASPEN ones quite a bit for now. But again, taking a look at all of that literature, they also tend to agree that if a patient is not able to meet their nutritional needs through oral intake, we should move ahead with enteral nutrition support, especially if the gut is still functioning. Here are the reasons why we may want to avoid enteral nutrition, including contraindications to enteral nutrition. So that's there for your reference. But regardless, due to a number of factors over the last few decades, right, the better treatment of critically ill patients, lower mortality there, more discharge, combined with the fact that all of this data is emerging on the benefits of enteral nutrition, this has led to a tremendous increase in the home enteral nutrition prevalence. This is data from our study, and we compared it to work by Dr. Lynn Howard in the mid-90s, and you can see the prevalence of home enteral nutrition has almost increased threefold. So with that, data, when we're looking back at our patients and what's our next step, we also agreed that we felt her gut was still working. We wanted to see if it was something in the esophageal jejunal anastomosis, and could we bypass that and provide her feeds. So we went ahead with a G-tube into the remnant stomach and started providing feeds that way. So the next question ahead of us was, well, what formula do we start with? Again, we're starting to have a lot of choices, and kudos to the companies that continue to innovate in this field. But we've got big categories such as standard polymeric formula, those semi-elemental peptide-based diets, elemental formulas, and I think even a fourth category that we can add now, which is blenderized tube feeding. They're going to vary in terms of their macronutrient composition, including the peptide-based diets, which is going to utilize more hydrolyzed protein. So we're giving more di and tripeptides. And then the lipids also can change in macronutrients, comparing long-chain triglycerides that we may see in the standard polymeric formula to those using mostly or at least half as medium-chain triglycerides. And later on, I'll go into some of the theoretical benefits of those. But for our patient, we had the same decision. We were looking at all of our options. Do we go with standard polymeric formula? Do we add fiber? Do we not add fiber? Do we try and aim for a high protein formula, again, with or without fiber? Do we start right off the bat with peptide-based diet, or we think tube feeding is not going to work, and do we go with parenteral nutrition? So when looking at this, again, looking at the guidelines, the home enteral nutrition world needs a great deal of work. In terms of guidelines, so sometimes we have to extrapolate from other guidelines and recommendations. And in this case, most would tend to agree that standard polymeric formula is the way to start. So that's what we did. This was how we did it, and we chose the high protein formulation. But unfortunately, within a few days, as the formula increased in the volume that we were providing, she called us right back and said, unfortunately, she's having bloating with her feedings, increased abdominal pain, felt that it was like an ice pick moving around, and also was constipated. So now what do we do? Do we think that this is related to the constipation? Would adding fiber help? Do we think this is a component of malabsorption? And in that case, do we go with pancreatic enzymes, or do we go with the peptide-based diet? Do we think it's a fact that we're providing sort of gravity feeds and it should be continuous? Or, do we think about parenteral nutrition? So with this in mind, I started reviewing the literature and looking at intolerance. Again, a lot of work needs to be done, I think, for these patients to better define this. But if we look at the literature, especially the critically ill literature, ill patient literature, almost 30% in this one study, that was a retrospective review, showed that there was some component of intolerance. Again, they were also including large residual volumes, which we are starting to move away from, but many patients also had distension, vomiting, diarrhea, and discomfort. And this led to decreased calories being provided. Another study also looked at this, both for the ICU patients and then the non-ICU, non-critically ill patients. And they found that even in the non-critically ill patients, they still had high rates of intolerance. Again, what was a major shift, and I think very interesting, was that in the ICU, it was those residual volumes that was largely causing feeds to be held, whereas when they moved to the hospitalized patients, you started to see that it was more nausea, vomiting, more abdominal pain, distension, and even more diarrhea that was leading to issues providing enteral nutrition. So in our case, kind of looking at this, I think we prepared ourselves that intolerance is quite high and we should try to work with her. We still felt that perhaps it was constipation based, and so added some fiber to her formula. But unfortunately, her symptoms continued. And I bring this up because when we looked at this case, it really struck us the term healthcare utilization. So as this patient was not tolerating her formula, she was greatly using healthcare resources. She was calling us almost 7 times over this time period. She actually went to the ER. She had a CT scan, which was unrevealing. But as you go through that mentally, you can see the cost is starting to add up. So we don't want to neglect this intolerance and say, well, it's quite common. We need to develop strategies for intervention quite rapidly. And again, what would those interventions be, right? And I've listed the options here. In her case, we sort of continued along the path of providing enteral nutrition, sticking with the standard formula. Our group was very conservative in switching to other formulas such as peptide-based due to our perception that those formulas cost more. So we're trying to be, mindful of the healthcare resources that we use. So again, we continued along this month after month, and you'll kind of see we tried to change to continuous feeds. We added formula. We consulted GI. They recommended some Miralax and other medications. We stopped her oral intake. But over this time, her weight continued to decrease. She was calling our group constantly. There were a number of other consults that she went through. So finally, in the fall, we then transitioned her to peptide-based diet. And again, by this time, we were very nervous receiving messages from her. So when we finally got a message, we all looked at it and said, oh boy, let's see what is happening now. But to our delight, she was very pleased with this change, and in fact wrote, the symptoms of pain, bloating, gassiness, and general feeding difficulties have all but resolved. I'm starting to feel stronger, having more energy, doing my ADLs now without much effort. She said, I really feel that all of the changes I've made have definitely shown great benefit, and I'm so happy. So kind of a delightful message to get, from a patient. This is what we want. But it also prompted us to start looking at the literature and saying, is sort of our algorithm of treating intolerance appropriate based on what's out there and based on the results we're getting for our patients? And when we did that, there's a number of studies, and I'll again go through these quickly for the sake of time, but there's a number of studies that have compared peptide-based diet to parenteral nutrition. In this case, it was in patients with abdominal surgery, and they showed that most of the patients on the peptide-based diet post-surgery were able to tolerate enteral nutrition well and avoided parenteral nutrition. They again listed the cost difference between peptide-based diet versus parenteral nutrition. Another trial looking at pancreatitis. So this is, someone we know and love, Dr. McClave's study, looking at 30 patients that were randomized to either peptide-based diet or parenteral nutrition. These are the calorie targets and the protein targets. And you can see overall, enteral nutrition was just as good as parenteral nutrition, if not a little bit better in terms of trends. But again, cost-wise, there was an astronomical difference. Same thing. Now there's another group of studies that have compared peptide-based diets to standard polymeric formulas. In this trial, we're looking at patients with pancreatitis, again, randomizing them through jejunal feeds. And what they found was that tolerance was pretty equivalent. However, in the peptide-based group, the length of hospital stay was shorter, almost 4 days shorter. Again, so this started to, change in our mind, this concept of healthcare utilization. We were comparing standard polymeric formula to peptide-based diet directly and looking at the cost of that, but ignoring the rest of the healthcare utilization, including the cost of 4 days of hospitalization. So you can imagine that. Another trial looking at the HIV cohort, 80 patients here. And again, they showed with the peptide-based diet, those patients were able to maintain their weight better, maintain their fat mass, and again, had less hospitalization. So this then led us to our own retrospective review. We looked back the last few years and saw that we had almost 95 patients that were placed on peptide-based diet. Out of those, 53 were started directly and 42 were switched from another formula. So when we looked at that closely, again, this is a retrospective review. So we looked at the clinicians and how they were making those decisions. We started to see that they were making those decisions largely based on the thought that these individuals would have malnutrition. And so more of those patients were started on peptide-based diet. So this is the indication for that peptide-based diet. Again, more malnutrition in those started from the very beginning versus those who were switched. Most of the time that was occurring due to intolerance of a previous formula. Here are the formulas that were used by our team. But this is really the slide that kind of hit home for us in terms of our algorithm of how to treat this. Those individuals that were transitioned to peptide-based diet, you can see the dramatic reduction in symptoms. Nausea, vomiting was cut almost in half after the transition. Diarrhea, cut almost in half. Significant reduction in abdominal pain and cramping, significant reduction in abdominal distension, and the patients with no symptoms, no issues, increased from almost 21% on previous formula to close to half on peptide-based diet. So pretty dramatic. But we also looked at healthcare utilization within our own group. And what we saw was that the number of phone calls that were initiated by the patient with complaints of intolerance were dramatically decreased. The number of ER visits based on home enteral nutrition intolerance were decreased, and then the number of visits were decreased. So it's very hard to kind of put this in terms of cost, right? Because of the way the U.S. healthcare system is and how the costs are sort of proprietary almost, the way they're negotiated. But if we look at the literature and try to look for equivalent studies, we can find some. So there's one study that looked at the average cost of ER visit for someone with constipation. And in 2011, it was $2,300 on average. So you can imagine what it is today. Another study looked at the managing of diarrhea and found that it ranged anywhere from $3,600 to over $5,000, especially if hospitalization was utilized. So I think as we look at this, we have to start putting all of that into the equation to see what is the best cost-effective manner to treat intolerance. Fortunately for us, we saw this abstract, I believe it was in ASPEN last year. Again, looking at this in a similar way, they were able to look at medical claims data for adults receiving peptide-based diet. So had much higher numbers, over 2,200 patients, and they found very similar results to ours, so which was quite reassuring. But again, dramatic reduction in symptoms of intolerance, and also a dramatic, statistically significant increase in patients who reported no intolerance with peptide-based diet. Just a few slides left on some of the theoretical basis for this. And what I've tried to show here is that, when we consume a standard polymeric diet or blenderized tube feeding, most of the protein is in the form of a large polypeptide, and that needs to be broken down into di and tripeptides. And then it's absorbed essentially through a number of channels there, including one that I think is becoming more important, is that's the PEP-T1. And I bring that up because what we're starting to see is that with studies that are looking more at this particular receptor, this helps us absorb di and tripeptides. Normally, it's really expressed in the duodenum and ileum, but in this study, they looked at short bowel syndrome patients and found that when the bowel was shortened, you started to see increased expression in the colon as well. So could the theoretical benefit of providing directly di and tripeptide is that could we be absorbing those proteins better? And that's why we're getting those results. Same thing with lipids, right? Most of our lipids come in the form of this large lipid droplet, and that is worked on by bile salts to emulsify it, and then the lipase breaks that down, releasing free fatty acids, and then that's absorbed through chylomicrons. With medium chain triglycerides that are found in these sort of peptide-based diets, those tend to get absorbed directly. And also, when we talk about oxidation, more of those long chain fatty acids need the carnitine transport to get across the double membranes of the mitochondria to be oxidized, whereas medium chain triglycerides can go in directly. So, with that, I'll close for the sake of time, but just to mention, home enteral nutrition is definitely increasing in prevalence, and I think we definitely need to develop a protocol for treating intolerance that includes peptide-based diets.
Thanks, Manpreet. I couldn't help but notice your patient got much better after you got a gastroenterology consult, but we'll say it's due to the formula alone. We burned up with questions from the audience, and I'm sorry we can't get to all of them, but I'm going to ask one question each to the speakers. Zudin, I'm going to start with you. That was a fascinating discussion of the urea-creatinine ratio. Why do you think the protein increases mortality? And secondly, what percent of patients do we see the increased ratio? And do you use that ratio or clinical measures of inflammation and mobilization to decide when to advance your protein?
Great. So that's three questions. First question is, why does the protein...
Why does it cause mortality? Yeah.
So we think, it's a hypothesis, and I'm hoping to answer this question, is that while urea is not toxic, right, the byproduct of that urea cycle and increased protein is ammonia. And ammonia is toxic for your mitochondria and your protein synthesis. And if you join us, Steve, you're going to join us because we're talking together in the next session about this, and I'm going to talk a bit about ammonia. That's one. Mm-hmm. The second question was about...
what percent and what you use as your measure to say, okay, I can increase protein.
Fine. So what percentage is, we don't know, because we literally have been working on this nonstop since last year, but we think it really depends on how sick the patients are. So you can see in the redox trial where they recruited really, really sick patients, we see it in multi-organ failure. So that's when we start to see it. And in keeping with good practice, because these are observational studies, and retrospective analyses of randomized controlled trials, I cannot recommend that you change your practice right now. We are going to test this in a prospective randomized controlled trial, and we will practice good evidence-based medicine.
All right. Okay, Manpreet, feeding intolerance is an absolute can of worms. I've looked at this area. Nika Blazer from Estonia has spent a decade of work in this area. The definition over almost 90% of the time is based on high residual volumes, which is problematic. Nika Blazer adds things like presence of GI bleed, increase of intra-abdominal hypertension or pressures. How would you define feeding intolerance in this situation, and what parameters should we look at? And why would the peptide-based formulas work in that setting?
Yeah, I think when I reviewed the literature, that was the biggest difficulty I had. So I tried to look at, data that didn't look at gastric residual volume. And a lot of that data is coming from the non-critically ill patients. So there, when we look at intolerance, they essentially defined it as any sort of symptoms that led to a holding of the enteral feeds or prevented the patient from reaching their goal enteral feeds. So again, not a lot of literature present in the home population, but those are the criteria we tend to use. So any sort of GI discomfort, bloating, gas, all of those things that prevent the patient from reaching their goal feeds. So that's how we would define it. Okay.
So let me ask the follow-up question. Several of the audience participants mentioned cost. You were comparing your cost to parenteral nutrition, but what about the cost of the small peptide formula versus the standard polymeric formula? Do you get into problems with coverage for that?
Absolutely. And I think this is where, healthcare insurance has to catch up, because we were directly comparing peptide-based formulas to the standard polymeric and saying that the cost of those peptide-based is too high. And because of that, we should do everything possible to see if the patient can tolerate it. We weren't accounting for the cost of the phone calls, the cost of the visits, the costs of the GI, the gastroenterologist who clearly fix, all of the problems, but regardless are quite expensive. Then the cost of ER visits, the EGDs, all the workup that goes into trying to solve that intolerance. So a lot of work has to be done, but I think when we start to put this together and compare the overall cost of intolerance, especially of not reaching goal, comparing that to the cost of peptide-based diet, I think you're going to start to see more adoption of this approach.
All right, that's great. We appreciate all these speakers. This was a fun symposium. Thanks for all your contributions, and we do need to close because we got to get ready for the next symposium.